I think, of course, this case demonstrates benefit after even 25 years. So we think that earlier intervention could prevent that long-term dysfunction and definitely needs to be investigated. Um, but, to bring it back sort of to the science, the shockwave's proposed mechanisms are angiogenesis, neurogenesis, and then reducing those fibrotic markers, fibrotic tissue markers. So it could be really valuable. What we think is potentially in that subacute, maybe 6-month postpartum period when scar tissue is occurring, like pathological scar formation is occurring, but it's not yet like fully established. So perhaps early application could prevent the development of that chronic pain pattern and pathological scarring rather than, in this case, like attempting to reverse decades of pain. But, in this case, even long-standing symptoms may respond to shockwave, so it could have value across the timeline. But certainly more research needs to be done in this area before we fully define when it can be the most helpful. I would say the key clinical features would be that localized scar tenderness and then the dyspareunia that is specifically related to the scarring. That's sort of what our patient experienced. And that was pain that interfered with her daily quality or daily activities of life and overall quality of life. So I would suggest perhaps that multifactorial chronic pain could also benefit. We have evidence that male chronic pelvic pain patients have improvements in quality of life, function, overall pain. Um, so for the practicing OBGYN, you asked what are the considerations in which to refer to that shockwave rather than just conservative management. And I would say perhaps the four main considerations, the first being persistent and distressing pelvic pain beyond, let's say, 12 weeks postpartum. So despite that standard NSAIDs, despite the analgesics that we would otherwise give. Um, the second consideration, I would say, is a symptomatic episiotomy or a laceration that causes the pain and dyspareunia or functional limitations. The third consideration, I would say, is that failed response to pelvic floor physical therapy. So, what I said earlier was around 8 to 12 weeks of failed physical therapy could be a consideration for shockwave. And then that last consideration are just patients who may need escalation to pelvic floor Botox or injections and are, declining that for various reasons. This could be a more conservative option before escalating the care. I'll start by saying that shockwave, what we know about shockwave that's been reported in the literature is that it has an excellent safety profile in pelvic and perineal tissues. Like I've mentioned, it's now a grade A recommendation for male chronic pelvic pain and chronic prostatitis. So if it's been safe and effective for penile tissue with no side effects, no need for anesthesia, there's limited reason to believe it would impact the female genitourinary tissues as well. But certainly, counseling could include discussion and shared decision making, first of all, and discussion about things like discomfort during treatment. Patients can experience mild discomfort during the therapy, even though we don't need topical anesthesia or anything like that. The second, I would say, consideration to discuss is the treatment course and sort of realistic expectations of timeline. What's been reported in the literature is that shockwave therapy usually requires, anywhere from 4 to 12 sessions over several weeks. And improvements can be slow and take some time to see any impact. So patients, at least studies in male patients, have shown benefits at anywhere from 4 to 12 weeks, even post-treatment. And then I would say, certainly we need to discuss that there's not a lot of evidence in postpartum populations. So we have this robust evidence base in male chronic pelvic pain, but the data just is limited in our postpartum population.